I'm going to talk about our preoperative and perioperative Staph aureus screening, decolonization, and prophy protocol, which has evolved in the age of COVID. Next slide. So some of these slides may be familiar to those of you who came to my presentations in 2015 and 2016 when we first rolled out our decolonization protocols. So just some background. We know, of course, that patient colonization with Staph aureus, both MSSA and MRSA, is a risk factor for postoperative Staph aureus surgical site infections with a relative risk of around 7. We know at Providence that Staph aureus causes up to 50% of surgical site infections in selected surgeries, and I'll show that in a little more detail in a bit. And we know that the anterior nares is the most common, but not the only site of colonization with Staph aureus, so we often direct our decolonization protocols to that site. Next slide. So we look to decolonization preoperatively because we know that eliminating the colonized state can reduce the risk of subsequent Staph aureus surgical site infections, and hospitals all over have developed programs that sort of seek and destroy colonization. So determining if someone is colonized and getting rid of their colonization prior to surgery for certain high-risk procedures. We target specific procedures, and those are generally those with the most data to support the approach and the best benefit to cost ratio, and that is generally cardiac surgery, including CABG and valves, orthopedic implants, and neurosurgery. Next slide. So what makes a procedure high risk? Those that are clean surgeries, those that I mentioned, we know that Staph aureus plays a larger role in those than in others like colon surgery and GYN surgery, where we expect other gut and pelvic flora to play more of a role. Surgeries in which there is implantation of hardware because the need for repeat operations and prolonged treatment protocols is real in those. So any situation in which we're putting in joints or hardware or spine reconstruction. Also surgeries in which there's severe morbidity and mortality, so sternotomy and craniotomy procedures where repeat surgeries are devastating to patients. And generally these are publicly reported surgeries. You'll see below those initials are how we report these to NHSN, which is our reporting structure. So it's hips, knees, laminectomy, CABG, valves, which is CARD, fusions, and craniotomies. Next slide. So how do we do this decolonization, and does it work? So regimens used are varied. So there's no one regimen that is used across the board. Most centers use a combination, as I mentioned, of nasal antibiotic to get rid of nasal carriage, or an antiseptic, so mupirocin, povidone iodine, and others, and also skin decontamination, since we know that staph lives on the skin. And this is generally accomplished with chlorhexidine or CHG. We know that decolonization is effective in the short term, but recolonization does happen, so it's not meant to be permanent. And we know that this short-term effect is beneficial because we want it around the time of the surgical incision and not necessarily after. And we know that decolonization reduces the risk of Staph aureus surgical site infections, both MSSA and MRSA, by 50% or more. Next slide. And we know that our national guidelines do support these protocols. The Institute for Healthcare Improvement's Project Joints included this in their how-to guide to prevent surgical site infections for hips and knees. Thoracic Surgeons Society endorsed this type of program in 2007. Another healthcare quality organization developed a consensus algorithm for preoperative decolonization for both orthopedic and cardiac surgery. And it's also been endorsed as an additional approach in preventing surgical site infections in cardiac and some orthopedic procedures in an update by the Society for Healthcare Epidemiology and the Infectious Disease Society of America. Next slide. So is Staph aureus a problem in Oregon? The short answer is yes. So I looked back at all of the Oregon region's data in the hive from 2018 through 2020 for the high-risk procedures that I mentioned previously. So in 2018, a quarter of the deep surgical site infections were caused by Staph aureus, and these are both MSSA and MRSA. In 2019, it was about the same place, 24% of deep surgical site infections, and in 2020, that increased to 40% of deep surgical site infections caused by Staph aureus. So Surgical site prevention, of course, has many elements and is not just about decolonization. It's part of sort of a bundle for safety. So we do the screening for Staph aureus and decolonization if it's present, and we'll talk about how to tweak that in a moment. There's also patient hygiene and getting the preoperative chlorhexidine bath. We use clippers and not shaving of the skin, hand hygiene, of course, by all healthcare workers, perioperative antibiotics, giving the right dose, the right antibiotic at the right time, operating room sterility and sterile behaviors, and postoperative wound care are all elements to surgical site prevention. So in the past, this might look familiar too to you. In the past, we had two screening or decolonization protocols. So protocol 1 was that we would do both MRSA and MSSA screening. Patients would get chlorhexidine the night before in the morning of surgery. They would get chlorhexidine in the pre-op area, and anyone who screened positive for MRSA or MSSA or had a history of MRSA would be given a prescription for mupirocin to use at home the 3 days before surgery and then 3 to 5 days after. They were not given povidone iodine because they were using mupirocin. They did not do oral care. They, of course, got standard antibiotic prophylaxis, plus or minus Vanco, depending on whether they were MRSA colonized. Protocol 2 required only MRSA screening. These patients also got chlorhexidine before surgery. These patients did not get mupirocin because instead they got povidone iodine nasal antiseptic. And this was given to all patients, regardless of what their nasal screen showed. CHG oral care was optional. They again would get surgical standard antibiotic prophylaxis and would also get vancomycin if needed. So here, because we were giving the nasal antiseptic to everyone, we did not need to know if they were MSSA colonized like we did with the mupirocin. With the mupirocin, we only gave it to those who were colonized. The only thing that we needed to know with protocol 2 is whether they were MRSA colonized, because that would determine that they needed perioperative vancomycin. Next slide. So why were there two options? Some ministries expressed an interest in a simpler approach, which was thought to be protocol 2. It was just given, the chlorhexidine was still given preoperatively, but the povidone iodine was just given at surgery. It was thought to be reasonable option, even though at that time there was less data for using povidone iodine in the nose, but it appeared favorable. And again, as I mentioned, the second protocol involved screening only for MRSA to allow correct antibiotic prophylaxis, but all patients got the intranasal decontamination, plus or minus the oral. Next slide. So there have been issues related to the use of mupirocin ointment, which I will outline. So one is some concern for development of mupirocin resistance, which I will talk about. There is concern about compliance with nasal mupirocin in the outpatient setting. Are patients actually picking up their mupirocin? Are they actually using it as directed? It has been non-operational for virtual visits in the pre-op clinic because their patients are not getting nasal screened. And I will talk about that more in a moment. There is the potential expense to a patient for the prescription for mupirocin. There have been shortages in the time of COVID of MSSA and MRSA NAT testing. There was some concern too about patients using intranasal mupirocin in the days prior to surgery and then getting their COVID swab, and would it interfere? Nobody truly knows the answer to that, but it was certainly a reasonable concern. And it's not useful for urgent or emergent surgeries because you're not having a 3-day before ability to give mupirocin. Next slide. So the concern about mupirocin resistance, it can happen both in MSSA and MRSA. It is a higher risk for those who use mupirocin frequently, which makes sense. The more you use it, the more the bacteria seizes it and develops resistance. So people who use mupirocin frequently for wounds or other purposes have a higher risk for this. In general, there is a low prevalence of it, however. Next slide. This is just a table that shows, at least in 2015, the sort of rates of mupirocin resistance. And the left-hand column is Staph aureus, which is what we're talking about today. 75% of them are sensitive. There was about 17% low-level resistance and 8% high-level resistance. So it exists in small amounts, but it does exist. Next slide. So how does povidone iodine work or how does it perform against staph that it has mupirocin resistance? So this slide here shows both a low-level and high-level mupirocin resistance in MRSA. The x-axis shows what treatment they were given. The y-axis shows how many bacteria were isolated. And you'll see that for all of these measures, the control had high numbers of bacteria, not surprising. B nasal is Bactroban or mupirocin. So those also, when there was resistance, they did not kill bacteria. And SMP scans for skin and nasal prep of iodine. So that's povidone iodine. And you'll see that after 1 hour and even 6 and 24 hours, that the levels of MRSA present were low with the treatment with the povidone iodine. Next slide. So changes to the pre-admit clinic since COVID-19. So as I mentioned, some visits are being done virtually. The patients who are seen virtually don't get their Staph aureus swabs, and without a Staph aureus positive swab, they're not given intranasal mupirocin. So that process just doesn't work anymore. There's also, as I mentioned, some concern that even those who are contacted about using mupirocin may not pick up those prescriptions and use it. Next slide. So we also know that, as I mentioned, due to COVID-19 test production, the company that makes our MSSA NAT test has had supply issues. We just got an email that it's back online, but I think it was offline for several months. So we have MRSA testing, but the dual MRSA MSSA has not been readily available. And again, there's that concern about putting ointment in the nose that I mentioned. Next slide. So how does povidone iodine compare, or how effective is it? We're used to using mupirocin. What about povidone iodine? So this is a study in JAMA that was done in 2015 with orthopedic surgeries. This is just the gross numbers, so no statistics here, but you'll see that in the control group, there were more infections, both superficial and deep and organ space, than in the intervention group, the ones who got povidone iodine and chlorhexidine and mouthwash. Next slide. This is the multivariate analysis of the same study, and you'll see that the decontamination, which is the povidone iodine chlorhexidine group, had significantly less surgical site infections with an odds ratio of 0.24 versus the control, no decolonization. Next slide. So how do the two compare? So this is a study undergoing arthroplasty or spinal fusion. You'll see in table 4 that they looked at any surgical site infection, so not just staph. In both the intention to treat and per protocol groups, they were basically about the same. So povidone iodine did not perform any less well than mupirocin. And then in table 5, the same table, except this is particularly Staph aureus infections. And again, both of the groups performed basically equally. Even povidone iodine might have been a bit better. Next slide. This is just another study comparing how mupirocin works against povidone iodine. The left side graph is porcine tissue. The right side is human tissue. The blue line is the control. The orange line is an ophthalmic preparation of iodine, which is not very effective. The yellow, again, is bacitracin or mupirocin, and the gray is the skin and nasal prep of povidone iodine. Again, you'll see much less bacteria recovered, particularly after 6 hours. And even 12 hours in the human tissue when povidone iodine is used. Next slide. So side effects. We've heard some concern about the side effects of using povidone iodine. One of our surgical colleagues reported to Dr. DeVille that he had heard that if you put povidone iodine in the nose, you will permanently impair their sense of smell. I was not able to find that anywhere, and this study shows that, in fact, when people were asked about their symptoms related to the treatment, either mupirocin or povidone iodine, the mupirocin had significantly more rhinorrhea, congestion, sore throat than did the povidone iodine. So I don't think that that is a huge concern. Next slide. So I do have some caveats. Mupirocin is more widely studied. I was not able, for instance, to find a study of povidone iodine used in cardiac surgery. I can't think of a reason why it wouldn't work in that population as well, but I don't have studies to prove that suspicion. And again, yeah, most of these studies were in orthopedic surgeries when they were done. Next slide. So this is my last slide. This is our current preoperative screening and decolonization program going forward since about October. So here you'll see in the column that people who are not allergic to povidone iodine will get an MRSA swab only. Or if they have a history of MRSA, that does not need to be done in the last 5 years. Everyone now is getting CHG 5 days prior to surgery, so that is also a change. It used to be just the night before and the morning of, so they are getting more chlorhexidine. Everyone, of course, is still getting chlorhexidine bathing in the pre-op area. They're not getting mupirocin, instead they're getting povidone iodine. Chlorhexidine oral care is not really taken off, and there's not a great amount of evidence that it's needed, so we haven't been pushing that. And again, they will get standard antibiotic prophylaxis plus or minus Vanco as needed based on the results of their MRSA screen. The only people who we would still rely on mupirocin would be those with a known povidone iodine allergy. That is my last slide. Thank you.
Thank you so much, Dr. Plotinsky. That's awesome. I appreciate it.